The challenge with breast cancer is that historically it's been considered to be somewhat of a non-immunogenic tumor. So it's been somewhat challenging to develop immunotherapies in that space. I started translating immunotherapies into the clinic back in the early 2000s and had developed a whole cell breast cancer vaccine that secretes GM-CSF, GVAX. And we tested it in combination with low doses of chemotherapy as well as trastuzumab in 2 different trials that are designed to support the vaccine's ability to induce a tumor-specific T-cell response. In the first trial, we treated 28 women with ER-positive metastatic breast cancer, and we sequenced the vaccine with a range of low doses of cyclophosphamide and doxorubicin, where the cyclophosphamide was being used to mitigate the influence of regulatory T cells, and doxorubicin was used to promote effector T cells. And the goal of that study was to identify the doses of chemotherapy that could maximize the level of immunity induced by the vaccine. And we identified a dose of cyclophosphamide of 200 mg per meter squared as the best dose to support vaccine-induced immunity. And that's lower than the dose that's been traditionally used in vaccine trials. And we've taken that dose forward in other trials of similar vaccines at Johns Hopkins. We had our vaccine trial that was in combination with both cyclophosphamide and trastuzumab. The trastuzumab was at standard doses, and that also looked very active. Last year at AACR, I presented the first data of more than a handful of patients for atezolizumab, the anti-PD-L1 agent, in patients with metastatic triple-negative breast cancer. They were pre-selected, and as a single agent in that small group of patients, there was a response rate of about 19%. That agent's moving forward into different combinations in a variety of different cancer types. One trial is testing it with an IDO inhibitor. There's another trial that's testing it for HER2-positive metastatic breast cancer, as well as early-stage breast cancer in combination with standard HER2-directed therapy, where the PD-L1 is given with trastuzumab and pertuzumab, or with trastuzumab and tansine in metastatic disease, and with those agents in a window study in the neoadjuvant setting as well. As I started off the interview, I said that historically breast cancer has been considered a non-immunogenic type of cancer, so it's been challenging to translate immunotherapies into that disease. There's accumulating data to suggest that breast cancer can be immunogenic. In particular, there's 2 subtypes of breast cancer, HER2-positive breast cancer, as well as triple-negative breast cancer, that appear to be associated with higher T-cell infiltrates at diagnosis than, for example, luminal breast cancer or ER-positive breast cancer. So those 2 subtypes in particular are very attractive for developing immunotherapies just because of that. Those higher T-cell infiltrates are associated with improved clinical outcomes, better complete pathologic response, or a higher likelihood of complete pathologic response to neoadjuvant therapy, as well as longer progression-free and overall survival if women have higher T-cell infiltrates at diagnosis. That's less likely for the ER-positive or luminal cancers. Well, the trials that I mentioned are Genentech-sponsored trials. I think those are very interesting immuno-oncology combinations, anti-PD-L1 and IDO inhibition together, as well as anti-PD-L1 with standard HER2-based therapy. I think there's going to be more and more interesting immuno-oncology agents that come out, and I think the biggest challenge for the field is determining a strategy for transforming non-responders into patients that can potentially respond to immunotherapy. There's a variety of different ways to do that. Some standard chemotherapies can do that. Radiation therapy can do that. And there are emerging agents that can really modulate the tumor microenvironment to make it more conducive to T-cell activity as well. So I think the most potent things to come along will likely depend in part on the specific tumor type, as well as the baseline immune profile of the tumor itself. And I think it's a very exciting time in cancer research, and particularly in cancer immunotherapy for patients with all types of cancers. I'm firmly convinced that we're going to be able to make cancer immunotherapy a reality for the vast majority of patients. And the strategy for, as I mentioned, for different diseases will vary somewhat depending on the baseline immune infiltrates that are present, as well as the biology of the tumor itself. So I think the future for cancer immunotherapy will tend to be more one of personalized medicine, where you really do an in-depth profile of the immunobiology of that tumor and really tailor the type of immunotherapy to the biology of that particular cancer.